Thank you. I would now like to invite Dr. Jason Chandler to the podium to give updates in hematology.
All right. Hello, I'm Jason Chandler. I'll be doing some cases in malignant hematology. I didn't specify that there. I'm from West Cancer Center. So I was trying to think of something that whenever we talk about malignant hematology, it's multiple different diseases, and I'm sure that's true even in breast cancer as you're dealing with all different subtypes. But what I tried to do was pick 3 areas where there seems to be a paradigm shift over the past several years. We treated patients with one approach, and then we changed, and lots of new updates came along. And so, and they go from kind of the rarer that someone in the community may not necessarily see to pretty common, which almost all oncologists treat. So we'll talk about how the paradigm shift changes and how it changes how we approach a patient and what our goal of therapy for them is. So first case presentation, this is a 66-year-old gentleman. He presented to an ENT with difficulty swallowing. They did a laryngoscope, and his nair, so that says near, but he had a near complete obstruction of his right nares, and so they did a biopsy of it. The patient had a history of hypertension, lots of anxiety, depression, substance abuse. He had a previous history of atrial flutter and had an ablation. He's divorced, lives alone, had smoked but quit, and did not really have much family history of cancer. So he has a mass in his sinuses. And so his white count you can see there with the neutrophilic predominance, pretty good blood counts, fairly normal chemistries, and liver function tests. And these are all going to be blood cancers. So the biopsy of this lesion showed a B-cell lymphoma. So it had CD20 on it. There was co-expression of CD5, CD10 negative. The Ki-67, measuring how proliferative it is, was 40 to 50%. And so initially the cyclin D1 stain failed. So for this situation, we see this frequently. There's a phenotype, which can be a couple of different things. You think about CLL or mantle cell lymphoma, which we treat very differently. And so for these patients, we always want to get testing to kind of verify and tell, is it mantle cell or is it CLL? And the patient had a PET scan, he had disease above and below the diaphragm. So I will, at different times in my presentation, include a pregnant pause for you to think about it. So I'm sorry if it's quiet for a second. I was thinking about it. This is what my daughter, who's 15, would call this cringy feeling. So I don't know exactly. I think I know what cringy means, but she uses it a lot. So we'll be quiet, and so that forces you to think about it and think, what is this? What would I do? Okay, that's enough cringy. So the patient had FISH testing done and followed up because the cyclin D1 stain had failed. And so he had an 11-14 translocation. He was SOX11 positive, so he was a mantle cell lymphoma. So 66 years old, you can see he has some cardiac issues, substance abuse, maybe not the best support system, stage 3 disease. And so you put a bunch of these elements into a calculator and you can get a MIPI score, which is their mantle cell prognostic index to kind of tell you, are you worried about them? Are they going to do good, bad? And so this is a high score. So when we're looking at, and I picked this one, this is mantle cell lymphoma, and we'll go into why because of new data. I know it's not the most common disease out there, but it's interesting. It seems like multiple drugs that get approved for lymphoma go to mantle cell first. And I think it has something to do with it always being like an unmet need. And so while companies say, I can get it approved there, there's a need for it, and then it's easier to get into other, for diffuse large or CLL afterwards. So a surprising number of drugs get chosen as an unmet need for mantle cell lymphoma. And so eventually, I guess, it won't really be an unmet need anymore when they have so many drugs approved for it. But when we're picking them, there's different subtypes of mantle cell lymphoma. There's about 10 to 15%, which would be considered in this indolent course. And in the past, we would have to just guess and watch them and say, are you behaving indolently? Is it possible we could maybe watch you for a little while? Is this the kind of mantle cell that almost would behave like CLL, like you could just watch them for a while? Or is it the kind that we're more familiar with where it's going to take off and cause life-threatening issues? So what's interesting is the ones that seem to have the indolent course seem to be more in the blood, almost like a CLL, and they're often SOX11 negative. And then the immunoglobulin heavy chain is more likely hypermutated. So that is a small subset. I would say this patient fell more into the regular, maybe 70, 80% of the aggressive course with the SOX11 positive. And then now in the NCCN pathways, they talk about testing your mantle cell lymphoma patients for P53, which is a common marker we use across multiple disease types. So it's not something that has always been tested. It's the mutation status, but it definitely has a poor prognosis, and it's so you may have to ask for that in your mantle cell lymphoma patients, because I don't think it's been a standard part of the workup. So mantle cell lymphoma, if you go back to what was done at MD Anderson, they kind of came up with hyper-CVAD as a way to treat it. And so this is a very aggressive treatment and multiple courses in the hospital, in and out. And so they were treating all of these patients aggressively and came up with this like 82% overall survival at 3 years. This is many years ago. And so multiple groups have tried to come up with other treatment options for that. So what we're trying to figure out here is discussing how do we treat this upfront diffuse large this upfront mantle cell lymphoma patient. So they had a Nordic regimen they looked at in Europe. And so what they did was they took R-CHOP and then they would alternate with DHAP, which is cisplatin and high-dose cytarabine. And so they would go back and forth and do one and then the other. And it was actually maxi-CHOP. It was like high doses of chemotherapy. So the approach at this time was like, can we cure these people? Can we hit them so hard with all the drugs and see if we can actually cure the mantle cell lymphoma? And then at the end, they would collect their stem cells and do an autologous stem cell transplant. So this is 6 very aggressive doses of chemotherapy followed by stem cell transplant. And they were like, if we hit it hard, maybe we can cure them. And so they followed them, and the patients seemed to do well. But you can see the curve, progression-free survival, there's no real plateau. It just keeps on, eventually the patients relapse. You can see that's 2 years, 4 years, 6 years. This is actually 15-year data follow-up that was published a few years ago. So we kind of were hoping, at the time they were thinking, maybe we're actually curing some of these people. But in retrospect, it looks like eventually they're relapsing. Seems to do pretty well. I mean, we're keeping them in remission for a while. But so the paradigm at the time was, let's cure them. Now, maybe let's think about how do we not beat them up so much with all these treatments. So more recently, they've done some meta-analysis to say, okay, what's the most important part of the regimen that we really need? And so they have had studies that came out with bendamustine taking the place of CHOP, and it was pretty amazing. They had really good response with just one drug, don't lose your hair, don't have as much cardiac toxicity as CHOP, so it's just one drug instead of like 3 or 4, and works really well. So that was studied. Then other meta-analysis said cytarabine seems to be the important part of the DHAP. So they looked at just doing the cytarabine and not doing the cisplatin. So two centers did this study, and so they combined them for this analysis. And so you were just getting bendamustine and Rituxan, which is pretty easy to give in comparison to MaxiChop or Hyper-CVAD, and alternate with cytarabine. And so these doses, initially they started out at 3 grams per meter squared and then kind of lowered it and got down to 1. And what they found is the lower doses you really need for those patients over 60. And then they followed it up with an autologous stem cell transplant. And so these are the curves before, and I know you can't really do the cross-trial comparison, but these, this is going out to 4 and 5 years, and these curves look really good for overall survival and progression-free survival, and they're much milder kind of induction regimen. So it's not so intense for these patients. So if your goal is not to cure them, you can treat them with this, especially if you have multiple other treatment options. And actually, these seem to do almost better than the more aggressive regimen. So this is a 66-year-old. He had multiple issues with cardiac and then also support system. So he ended up getting bendamustine and Rituxan, alternating with the high-dose cytarabine and Rituxan. And he definitely had difficulties with his treatment just due to social support, depression. And so when it came time to set him up for an autologous stem cell transplant, he was not going to be able to manage staying in the hospital for multiple different reasons. But he did get a complete remission after this, and so we put him on Rituxan maintenance. So for these mantle cell lymphoma patients, after you do all of that, you do this very aggressive treatment plan, then they will hopefully go years and years and years, or in his situation, we couldn't really give him everything we liked. He did relapse after a few years. And so the second line options that are out there, we have quite a few to choose from. And so it changes from hitting it hard and trying to cure it to more like trying to keep it under control. So multiple BTK inhibitors are out there and kind of preferred in the second line. There's multiple different treatment options available, but in general, second line, these are our 3 options. So ibrutinib, kind of first generation, acalabrutinib, and now zanubrutinib. So ibrutinib's been around for a long time, and each one has a little bit different side effect profile where we've been able to tweak it in the off-target effects. And so zanubrutinib is now FDA approved for mantle cell lymphoma after a relapse. And so this drug has similar side effect profiles, but has less AFib and aflutter, less hypertension. There still is some risk for hemorrhage for this, usually diarrhea, contusion like bruising, constipation. And you can see these response rates are pretty good. So you take a pill either once or twice a day, and it can really manage their disease. You're not going to cure them, but it's going to hopefully keep them under control for many years. So in this situation, the patient did have AFib and flutter in the past, so zanubrutinib is a good option. Ibrutinib and acalabrutinib are both good options as well. So in multiple areas, we do ask the question as far as this change in approach, like a paradigm shift. Do we really need autologous stem cell transplant anymore? So you saw we went from hitting them hard to just doing bendamustine and Rituxan, and the patients still did well. Do we really need to use a stem cell transplant for these patients? And so just recently at ASH, they had the triangle study that was a plenary session just back in December. And so the question it was asking is, can we get rid of stem cell transplants even in these like younger patients that are fit? So this was a phase 3 study. It had 3 arms, and so it was less than 65. These are patients that had to be strong enough and fit enough to go forward with the stem cell transplant. So you can see the different arms, and they're kind of abbreviated. So basically, you could get R-CHOP with ibrutinib, alternating with RDHAP. So you would add ibrutinib to it, and then follow that up with the stem cell transplant. So very similar to what, I guess the bottom one would be what we were talking about before in the Nordic regimen, where you'd go back and forth, stem cell transplant, and then just watch them. So the top ones, they said, let's add ibrutinib to it up front. Don't wait till they relapse, let's put it at the beginning. And so in one group, they added ibrutinib, still did the stem cell transplant, and then left them on ibrutinib maintenance. And then the second one, they just took out stem cell transplant. So they're saying, if we add the ibrutinib up front, can we just skip doing a stem cell transplant in these patients? Any takers to what happened? So on the left, you can see the progression-free survival. So the top two curves are the ibrutinib arms, ibrutinib with stem cell transplant and ibrutinib without stem cell transplant. And the bottom one was no ibrutinib. So, I mean, it is true you're on a pill, so it's like you just don't stop. So you would think that the progression-free survival would be better. But this is pretty impressive. It's so you're going to move a drug up front with those potential side effects, but not have to get a stem cell transplant. So this was pretty provocative at ASH to have this discussion, like, do we really need stem cell transplant anymore for these mantle cell lymphoma patients? And then on the right, you can see these are overall survival, little closer curves because there are so many treatment options available. But you can see how the autologous stem cell transplant, maybe if not statistically, numerically, without ibrutinib, is potentially a little on the, but they're pretty close. So stay tuned. I don't think by any means is this standard of care at this time. I think still stem cell transplant is still pretty prominently used, but it's an interesting shift of how we might someday not have to do this. So this patient, we talked earlier, he did chemo and then didn't go to transplant. He just went on Rituxan maintenance. He progressed and then was put on zanubrutinib, an oral drug, and he tolerated it well, but about 6 months later, he started progressing again. And so what are the treatment options? So just got FDA approved about a month and a half ago. This is a new drug called pirtobrutinib. And I'm sorry for those who don't take care of B-cell lymphomas that I know they all get thrown together in your head. Ibrutinib, acalabrutinib, zanubrutinib, pirtobrutinib. So I'll do my best to help you kind of keep them separate. There are all the older BTK inhibitors, which the B cell has on its surface something driving, telling it to grow, this BTK, and actually it's Brutus tyrosine kinase. So there are actually patients that are born with a mutation in this BTK pathway, and they don't make antibodies. Their B cells don't function. And that was one reason they knew to go after this pathway. So BTK is what we're blocking. And most of the drugs before would covalently bind. They would stick and not let loose. So ibrutinib, zanubrutinib, acalabrutinib, they would stick and not come loose. And so this drug just got FDA approved a month and a half ago. It's non-covalent BTK inhibitor. So I haven't had a chance to use the drug yet, but it supposedly has a different side effect profile because of that difference in binding, and these patients were all relapsing after they had been on another BTK inhibitor. So these patients do respond. They got the first generation, and you can switch over to the second generation with a little bit different mechanism of action, and it can work. And then the thought is that this drug will be looked at in multiple other B-cell lymphomas that use BTK inhibitor. So CR rate's pretty good. So we've got upfront plus or minus transplant, BTK inhibitor, next BTK inhibitor. And then now there is, well, for a few years ago, we have CAR T cells for mantle cell lymphoma. And these are excellent options as well. So these are patients either after stem cell transplant or after these treatment options. Basically, these last two, the pirtobrutinib and this, are both third line or greater. So we have multiple options. You can see the different curves here. The purplish curve in the middle would be like all comers, but those patients that do receive CAR T cell and get a CR, a complete response, they do great. You can see the blue curve at the top. They do very, very well going out, 5-6 years, and this is heavily pretreated patients. But in those patients where it doesn't work, you can see it really doesn't work well at all. So if the T cells don't take, or they don't proliferate, or not hitting their target, or become allergic, those patients, you either do well or you don't with this. So this is great. And I talked a little bit about CAR T, so I won't go into depth at our other conference previously, but this was the ZUMA-2 study and showing excellent outcomes. So in review, there's multiple options available for mantle cell lymphoma. It seems like the things that matter up front are Rituxan, some sort of chemotherapy, and the higher dose cytarabine. So when they do all the different evaluation to look at multifactorial analysis in retrospect, these issues are what matter. So whether you use bendamustine or CHOP or maxi-CHOP, you just need some chemotherapy with high-dose cytarabine and Rituxan. Stem cell transplant is still really standard of care in those patients that can tolerate it, but it's weakening now with these new possibilities of doing ibrutinib based on the triangle study. And then BTK inhibitors as a class, the covalent type, are second-line options with good side effect profile. And then third line would be the non-covalent BTK inhibitors, pirtobrutinib and CAR T, and both of these have excellent outcome. And then you still have those patients with allogeneic stem cell transplant as an option, but you can see how this is less likely with all the other options we have. So before we were trying to go for cure, maybe now we're trying to go for disease control with these patients. Okay, so mantle cell lymphoma. Next we'll do a little bit different case, a different kind of disease type. So this is a 79-year-old female. She had breast cancer 8 years ago and received chemotherapy and radiation. She started having some shortness of breath and bruising, and so she went and got her blood counts checked, and her white blood cell count was 0.5, her neutrophils were only 100, her hemoglobin 7, and her platelets were 30. She had normal renal and liver function. Her past medical history, she really just had hypertension, diabetes. She was very healthy and working part-time still, even though she's 79. She was very fit, but started feeling tired and bruising with all this. So basically pancytopenia, we just need to go to the source. So we do a bone marrow biopsy, or sometimes we can do peripheral blood, but she had a bone marrow biopsy, and it was hypercellular, 70%, and she had 15% blasts. They were CD34 positive. She had a complex karyotype and wild type TP53. So basically she has what? And the reason I ask that is it's 15% blasts is our cutoff, and traditionally 20% blasts was where we said it's leukemia, AML, and 15%, actually 19%, we would say it's myelodysplastic syndrome or high-grade myelodysplastic syndrome. And so it's been, this past year, they have these new guidelines, and this is from ELN, from the European Leukemia Network. They published, and there's two different kind of competing categorizations of MDS, AML, when's the transition. And so this is an interesting thing, and I think it's important, so I'll just kind of step you through it. So before, 20% blast, you had leukemia. 19, you had a high-grade MDS. patients that care for these people, we all knew you were right on that border. I mean, if you had 3 pathologists in a room and they all look at the same bone marrow, one might say 21% blast, one might say 19. Is there really any difference in this? And so what they did was try to show it more as a continuum. So basically, if you can look at the top, it says if you have more than 10% blasts, and you start going down the pathway here from left to right. So if you have a mutation, a genetic abnormality that we see recurrently in leukemia, and you got greater than 10% blasts, it's it. You've got AML with recurrent genetic abnormality. And they actually use these terminologies whenever they give you the report. And if you don't have those things, you've got greater than 10% blasts, you move to the right one step. So if you're mutated in TP53, greater than 10% of it, and you have 10 to 19% blasts, the designation is MDS/AML with mutated TP53, and if it's greater than 20, they just call it AML. And I think the idea is that way, both for approval of drugs, like we can actually give drugs that we would treat AML with, such as venetoclax, which isn't approved in MDS right now, but it is in AML. So this kind of gets you in that 10 to 19% range. They're calling it because they know they're very similar. Then you move to the right. Then they do the DNA sequencing. And so if you have all these mutations, like an ASXL, RUNX1, then you can say they're an MDS with myelodysplastic gene mutation-related changes. If not, the karyotype, you call it, with cytogenetic abnormalities, and then get to the very end, it's NOS. So basically, they kind of work their way from left to right, and when you get somewhere, you stop, and that's what you call it. So if you have a complex karyotype and TP53, you're still called like AML with TP53. So don't be confused if you get your report for your MDS or AML patient and something has changed. So these are the recurrent cytogenetic abnormalities that we were talking about. So if you have an 821 or a 911, these are mutations that we see, then even if you have like 11% blasts, you call them AML, because we know these mutations go along with AML and you can treat them accordingly. I mean, I don't know if this is a good time for questions, but if anybody has any questions, please hop in. So if we have a patient, this patient had 15% blasts, and she had a complex karyotype, and she was old, 79, I think, and she did not have TP53 mutation. So what we try to figure out is, what do we do for patients? In the past, again, the paradigm shift, most patients were either, when they had AML, they either got the sledgehammer of 7+3, and they would be in the hospital for a month. 15% of them maybe would die from the induction chemotherapy. And if you didn't cure them, then, and it came back, and it was just a very, very poor outcome. So you had just this small sliver of a window for those older, infirm patients. And so you're really having a tough decision. You're like, do I just go to hospice, or do I really try this only thing we got? So then hypomethylating agents like azacitidine came out. And so if you look, the purple is if patients had poor risk cytogenetics, they were TP53, say, wild type, and you got just azacitidine, you had about a 22% response rate. So, it's not really good. And then if you have TP53 mutated, it's only 16%. When you add venetoclax, it jumps up to 70% with wild-type TP53, and then on the left, it's just 40%. So TP53 mutation just does poorly. And the 70%, I mean, can you imagine a 79-year-old getting this regimen, which can also often be given as an outpatient? I mean, poor risk cytogenetics in general is a negative, portends negative future, and so this is a pretty good, pretty amazing response rates here. And then on the right, you can see some of these curves that show survival. So I think what's important is, if the top black line is patients that are TP53 wild type and got so on the left is just their remission rate, and on the right is how long they lived. So if they're wild type, whether you got AZA or Ven-AZA, if they were wild type TP53, you did pretty good. And if you were TP53 mutated, you did equally poor. You can see the bottom two curves just look really bad. So, so basically, if you have TP53, we don't have really great options. This patient, 79 years of age, she had complex karyotype, TP53 wild type, and fairly good performance status. So this is how we oftentimes treat these patients. So you think about your grandmother, lots of patients, the aging AML goes up pretty exponentially as we age. We keep getting more and more mutations in all our blood. I think if we checked, I don't know about all of you, but if we checked my blood, we would probably find a DNMT3A or some mutation in our blood. It's pretty common now, and they seem to be additive. And then eventually, if you get enough of them, that's when it happens. So as patients are aging, they're living longer from heart disease and other things. More and more of them are getting AML at an older age. And so this is a very common scenario. So this patient was able to get decitabine, 20 milligram per meter squared for 5 days. So it's just an IV treatment, pretty well tolerated. And then venetoclax, 400 milligrams daily. So this can be done as an outpatient, even in these patients that are pretty frail, but oftentimes we'll bring them in the hospital for the first cycle, and that's what we did for this patient. And we watch them just to make sure they don't need transfusions, make sure they don't have tumor lysis syndrome. But this specific patient, we admitted her, got a couple of weeks, and then discharged her home, continuing to take the venetoclax and checking labs a couple of times a week. So in the past, when you give 7 and 3, when you give the strong stuff, you're in the hospital for a month. And you usually check a bone marrow 2 weeks in to see if you did a good job, and then you wait for their blood counts to come up again. It's either you win or you lose. It's either it works or it doesn't, usually. In this situation, you treat them, and then you wait more like a month to check their bone marrow biopsy. So part of this is just kind of giving recommendations because the studies say give these treatments, but it took us a little while to figure out how to manage it differently than the old way we used to do things. So we wait a month and we check a bone marrow biopsy and we see how did we do. And say, for instance, they went from 15% blast to 5, you could actually do it another month and check again, and because it can actually continue to respond over time. In this situation, the patient had just an empty bone marrow, just about 5%, and there were no blasts present. And so what we can do is we can actually take a break for a week and let the blood counts come up a little bit. We can even give some growth factor support if needed, if they're in remission, and then start again and just kind of give this treatment and continue it as an outpatient. So even a 79-year-old can tolerate this. All their blood counts start coming up, can actually start feeling better. So some of the important things to remember with venetoclax, pretty easy drug to give, but in these patients, they're usually at risk for infections. So we're putting them on things like fluconazole or posaconazole. So because of the interactions, this patient, when she went on fluconazole, instead of taking 4 pills a day, 400 milligrams, she went down to 200 milligrams. So we just have to be aware of that when we're treating these patients. So this is about after a couple of cycles, all her blood counts started coming up. She was feeling well. You can see her counts there. Just even after a week of being off treatment, everything kind of recovered. So she continued this treatment, decitabine for 5 days, venetoclax. What you can do after this is start backing off and just doing the venetoclax for 2 weeks and then maybe coming off for 2 weeks to allow the blood counts to come up. And then in the next few years, she was actually able to go to a lower dose and watch her. And so no longer are we trying to cure these patients. We're just trying to keep their disease under control. So this is that was a pretty, we see this more and more in these elderly patients with AML that we can actually treat them and take pretty good care of them and extend their life with pretty good continued performance status and quality. So that's kind of one situation. She was 79. Here's a little different take. So this is a 66-year-old gentleman, and he actually had a mass on the right of his neck, and he had bruising. He was still working full-time and felt pretty good. His white count was 2.5. His neutrophils were 700, hemoglobin of 10, and platelets of 75,000, creatinine of 1. He's actually a school teacher, teaches history, has hypertension. So so he has this right neck mass. You can see his blood counts. And so I start going through, what possible things could this be? Could it be lymphoma? Could it be something causing marrow infiltration, suppressing his counts? And I didn't say that to be tricky. This is literally what we went through. We're like, does he have lymphoma? And then actually when we biopsied the lesion in his neck, it was a myeloid sarcoma. It was his AML that was actually causing a kind of a mass. So this patient has another AML, but he's a little bit younger. He's 66. His bone marrow is packed, 25% blasts, TP53 negative. And what happens is you do the bone marrow and it's leukemia. And then about maybe 4 days later, if you're lucky, you get some fish. Maybe a week, you get the cytogenetics. And then 3 weeks later, you get the next-gen sequencing. Sometimes we can get the FLT3 kind of quick because it will affect it, and they'll do like a PCR test right away. So that's kind of the order of events. And so we're trying to plan our treatments kind of with incomplete information because it would be really hard to wait 3 weeks to start a patient with AML on treatment. So he did eventually get all these results back, and so he had an ASXL mutation, this DNMT3A, RUNX1, TET2. He's got all these mutations, AML, 66, healthy, just hypertension, good renal function. So, so what are our options? So we've got this new thing that I was just talking about with Vidasa venetoclax or decitabine venetoclax. And then you've got the 7 and 3 old-timey chemotherapy, which still works. And so how do you make a decision in this 66-year-old? Is 66-year-old fit? Is this the patient we go stronger, weaker? How do we make this decision? And so this is an interesting article that kind of looked at it and tried to compare it, looking at all these different variables. And so this isn't perfect. I mean, the numbers are not massive, but what they were trying to say is if you looked at all these patients and then you kind of categorized them, such as those over 65, what do they tend to do better? And you can see over 65 tends to favor HMA venetoclax here, doesn't cross 1 here as far as confidence intervals and odds ratios. So, and then if they're greater than 65, it's kind of a wash. It's not really clear which way is best. Then you can talk about the ELN risk stratification, like good risk, medium risk on their DNA, and see, in the past, that's kind of how we made decisions on if we thought a patient was going to do good or bad, and that kind of doesn't cross. And then you start getting down here, and interesting, like RUNX1 mutation seems to favor Vidasa venetoclax or HMA venetoclax. So while up here, this M5 categorization seems to favor chemotherapy. So I don't know if this is standard as of yet, but it's, if we could get these tests back quicker, maybe in this situation, do we go the strong or the weak? There might be situations such as the RUNX1 mutation that maybe we would normally have done 7 and 3. Maybe we would switch them to HMA venetoclax. I'm sorry, I don't think this got copied because this is the identical one. So basically, they try to do some propensity matching to say, okay, well, what if you have a 65-year-old that has heart disease and all these things, and another 65-year-old that's super healthy. And basically, we're trying to figure out, in the 65-year-old, we really get stuck. If they look really fit and healthy, we're like, do we give them the strong or do we give them the weak? Especially 60, then 55. This is still an area of that we don't really know what to do. So this patient got 7 and 3, our old traditional chemotherapy. His day 14 marrow showed that the leukemia was all gone. If we look back, he had an ASXL mutation, RUNX1, DNMT3A, TET2, and F1. So he did get sick. He got a fever, but he was stable and recovered his counts. He, by day 25, his neutrophils were up. He was discharged home. So he was in remission. What do you do next? So in general, we waited till his blood counts totally came back up, and then we did another bone marrow. And everything looked good, but there were multiple mutations still. They didn't see leukemia, but they still saw these mutations there. RUNX1, TET2, DNMT3A. And we think some of these are often founder mutations, so sometimes they're gone, but RUNX1 is still one of the ones that we consider kind of a problem. So kind of with the RUNX1 and some of these mutations, ASXL from the start, we knew he was probably going to need a stem cell transplant. So even though he's in remission, he's being referred for stem cell transplant right now. So this is kind of how we're straddling, do we go aggressive or not? I will say for patients that have TP53 mutation, an option may be some of these newer clinical trials. We hope magrolimab, which is the don't eat me kind of signal drug that's coming along because HMA venetoclax does not seem to overcome that poor risk issue. Deeper remissions maybe with 7 and 3, outpatient less toxicity with HMA venetoclax, older patients. RUNX1, you may consider these options. So it's a complicated decision-making process, but I think you can't really go wrong either way in those patients 60 and older for either one of these options. And it sure is nice to take care of them as an outpatient. And be sure to back off on the dose intensity, and it's okay to use growth factors after you've confirmed that they're in remission when you use this HMA venetoclax option. All right, so that was mantle cell lymphoma, 2 ways of looking at how we take care of AML and how we're kind of changing how we look at it. Now here is another patient, a 57-year-old that had a neck swelling, night sweats, weight loss for 6 months. White blood cell count was 65,000. There was a lymphocyte predominance, just a little bit of thrombocytopenia and anemia. This patient had a pacemaker, coronary disease, was on cholesterol medicines, still pretty healthy and runs, and her mother had breast cancer at age 55. So a lymphocytic predominance, slight effect on blood counts. Peripheral blood was tested, and the phenotype may look similar to what we talked about before, but this time it was compatible with CLL. So basically, CAT scan showed disease above and below the diaphragm. I think probably in order of commonality, mantle cell, pretty rare. AML, more common. CLL, I think pretty much every oncologist, unless they're super specialized, will be taking care of patients with CLL. So basically, these patients, we kind of decide, how do we start? What's the first line treatment for these? And there's so many options available. This patient had immunoglobulin heavy chain unmutated status. So in this situation, being unmutated, mutated is the good one, unmutated is the less good one. And they had a TP53 was negative, and normal fish. So this was a pretty standard new CLL patient, not high risk. So this is what we have for NCCN right now as our options. And so you can see that they have preferred regimens off to the left. And on the top, it's acalabrutinib plus or minus obinutuzumab, and it's category 1. Obinutuzumab and venetoclax, category 1, and zanubrutinib, category 1. So they all have phase 3 data supporting them Actually, ibrutinib has category 1, but just because of side effect profile, they have a preferred and unpreferred. Then there's all these other treatments available. You can see to the far right, FCR. So that used to be our approach. Hit them with very strong chemotherapy, maybe in hopes of curing or just getting prolonged remissions. But this is, it's very rarely used, except sometimes in really young patients when you think you might get like a 20-year remission status. So this is a patient, pretty healthy, not has a little bit of cardiac issues. So we're trying to decide. For a while, it was FCR. Then many years ago, bendamustine and Rituxan was used. And so this was a study to say, upfront, CLL, can you do bendamustine and Rituxan for 6 months, or do continuous treatments with ibrutinib, or continuous ibrutinib and just do 6 months of Rituxan? So these were 65 and older patients, untreated. And interestingly, the ibrutinib with and without Rituxan did better, but the Rituxan didn't seem to add anything to it. So you did just the same whether you just took the ibrutinib or you added the Rituxan. And then you see the bendamustine Rituxan, they do well, and you only do 6 months of treatment, but definitely you get a longer remission with ibrutinib dosing. So that's why it had that category 1 indication. Ibrutinib up front, just, treat the patient, put them on it, leave them on it. The concerns would be things like atrial fibrillation, hypertension, bleeding. So you take a pill once a day. It's pretty easy to talk to a patient to say, yeah, you got this CLL, you're not feeling good. We can put in a portacath or do IVs and give you this chemo, and you're going to be here 8 hours, or you can just take a pill. And so a lot of times people will be like, I just want to take a pill. But you do have to be aware that, AFib, it will occur. These are the grade 3 events. And then hypertension, you can see how it kind of is more cumulative over time, the increased risk of hypertension. So this is a pretty good comparison because this is comparing it to BR, not just even placebo. So then another option we looked at in a study called CLL14, which was you do obinutuzumab, which is just a different CD20 antibody with chlorambucil, or obinutuzumab with venetoclax. So you see we're using these drugs for AML, CLL, many of these are overlapping across different disease types. And so this is untreated CLL patients, and it's basically a fixed duration dose. You do it for a year. And so you get the obinutuzumab for 6 months, and you get the venetoclax for a year, and then you stop. And then the other arm was chlorambucil, and then the obinutuzumab 6 months. And so venetoclax did a lot better than chlorambucil. And you can see these are the progression-free survival curves. And that one is a pretty long, flat curve for the venetoclax arm. And then these, interestingly, these are the overall survival curves. So for CLL, patients are going to respond for a long, long time, and you're going to retreat them with many of these drugs. So you didn't see any benefit in overall survival, and it's going to take many, many years before you do. And then this is just one other approach, which I don't think has been standard of care yet, but it's interesting. So we talked about ibrutinib, bendamustine, and Rituxan, then doing just ibrutinib, or obinutuzumab and venetoclax. This one is a different combination. You give ibrutinib for 3 months, and then you give a year adding the venetoclax on. And then if the CLL goes away where you don't see it, we don't think you're cured, but if it's MRD negative at the end, then this is a very interesting randomization where you can kind of direct therapy based on their MRD status. And so if they're MRD negative, then you go just to either ibrutinib or placebo, and if you're MRD positive, then you stay on treatment with ibrutinib plus or minus venetoclax. So this is where we want to go for diseases like CLL that we know we're not curing. So maybe we can guide our therapy with this. And sometimes we do it, but without data. to know if they're MRD negative, well, we can probably stop treatment for a while, but this is great that we will have studies that kind of prove and guide to us how we should approach these. So the top right-hand corner with the red box around it is the one we're going to look at. So these are patients that were MRD negative after a year and 3 months. And so they're MRD negative after a year of treatment with venetoclax and the ibrutinib. And so you, in one group, you kept taking the ibrutinib, and then the other group, you just stopped it. And you can see how close those progression-free survival curves are. They're numerically different, and the overall survival's looking great. So basically, if you get these patients MRD negative, whether you continue drug or not, and the dotted line is when they were randomized, they're going to do great if you can get them MRD negative. So that should be kind of a goal for us. This patient received obinutuzumab and venetoclax. After a couple of cycles, neutrophil count dropped, so we had to hold a cycle and then back off on the dose of venetoclax, which is common. At the 6-month mark, when you did 6 months of the obinutuzumab, we checked blood testing to see if there was any evidence of disease by MRD. And there's different levels of MRD testing. You can do a flow-based one, and this was and it's kind of not as deep, and it was negative. And then after the year of venetoclax, there's an even more sensitive test called clonoSEQ and repeat imaging, and the patient was completely in remission and stopped all therapy and was off treatment until now, and still following them, hopefully for many years to come. So for case 4, basically we have evolved over the years from FCR to bendamustine and Rituxan, and now BTK inhibitors and venetoclax-based regimens. I would say the principle to take home is that BTK inhibitors work really well for many, many years, but they don't ever get you MRD negative in general, very rarely. So they do great, but they don't make the disease disappear, so you have to stay on them. Obinutuzumab and venetoclax, or venetoclax specifically, can get you an MRD negative, so you can do it just for a year and then stop treatment, and patients love that. And then you can always go back to the other drug later. So both are completely reasonable options. Take a pill, like I said, patients like that, or a treatment where you give them and watch them for a year and then come off treatment. And zanubrutinib, the new BTK inhibitor, has a little bit better profile for hypertension and AFib than previous ones in head-to-head studies. That's all I got. I think I've got about 5 minutes or 4.5 minutes if anybody has any questions. Yeah.
Thank you so much, Dr. Chandler. Since you're treating these patients with oftentimes aggressive and complex regimens, is there a role for integrative oncology to kind of complement people living with so that it's more adherent to the treatments that you're providing?
What do you mean by integrate? You mean like a multi-D kind of social workers?
Or, talking to people about how they're eating, how they're moving, how they're managing stress, how they kind of help combat these longer aggressive therapies and balance their quality of life goals.
Yeah, I think it's like 2 parts of it. For sure, like that patient that had little social support. I mean, depressed. I mean, we have a psychologist on staff, and he was seeing her every week because we were trying to get him to the end of this so that he can have if not cure, a really long remission status, and it was a slog to get him through the treatments. So we do work on all those issues, as far as watching them for fevers, checking blood counts, transportation. So we definitely have a team. In kind of a different realm that I didn't bring up, it's interesting. So there's a disease, CML, and basically for it, you take a pill for the rest of your life. And the number one reason that people start relapsing from their CML is they quit taking their pill. And you would think, well, that's crazy. Like, you die of your cancer, you take a pill once a day, and you take that pill and your disease disappears on the piece of paper you show them, and they're like, it goes way down on their priority list. The first day you meet them, they're like scared to death. Then 3 years in, they're like, I'm in remission, and they say, I take it every day, doc, I promise. And you're like, you're thinking in your back of your mind, do they really? And they've done these studies where they have the bottle, and it measures when they open it and take the pills, and people say 100% they're doing it, but it's like 95, sometimes 90, sometimes 80. And I don't think people do it on purpose. I think it's just human nature that when things are going good, it's a different battle. Like when everything's falling down on them, they'll do whatever you say. When we have such good regimens that don't make you sick, they live longer. It gets harder, the compliance issues, kind of informing them, kind of keeping them accountable to keep taking their medicines, especially on these oral regimens they're on at home. You don't know if they're taking it or not. I mean, sometimes it's nice to give them an IV treatment because they got it in them, and then they can go home and do whatever they want. So it's definitely a different way to approach how we manage these patients. That's a good question.
And then we have 2 questions from
Sure.
our virtual audience.
Okay. So one was, can obinutuzumab and venetoclax be used as second-line treatment after BTK failure? It's not the way it's FDA approved. Actually, I think it's venetoclax and Rituxan is officially approved second-line after BTK. I mean, you could use it if you could get it approved, but actually the approval, the FDA indication is rituximab, venetoclax, and it works really well also. And then the second question is, do you give prophylactic anti-infective medicines to prevent infections for zanubrutinib? I'm trying to remember, most patients with CLL on BTK inhibitors in general, class effect, get infections, pneumonia, all kinds of infections. Their immune systems aren't 100%. Sometimes it's because their quantitative immunoglobulins are low. So oftentimes we'll put them on acyclovir for sure to prevent shingles. I can't remember in the package insert if it specifically says PCP or PJP pneumonia with Bactrim prophylaxis. I don't generally use that, but I do watch these patients closely for infections. And so if their IgG is less than 400 and they're getting recurrent sinopulmonary infections, sometimes we will give them IVIG to boost their levels up, just to get them over the hump, especially like winter months when they're getting frequent infections. So these patients, that is the main side effect issue, is getting infections. So those are good questions. And that's, I think that's exactly my time. So thank you guys very much. Happy. Yeah, sure.
And that is regarding patients with multiple myeloma.
Mm-hmm.
I know we can't talk about everything, and the time frame that you have. But I wonder if you mentioned anything about that, given the racial numbers
Mm-hmm.
in Memphis and surrounding areas, and hydrogen disparities.
Mm-hmm.
So, finding the great disparities in multiple myeloma and the various new drugs for treating the disease, but also the studies to prevent the disease. I wonder if you had just 1 minute to say something.
Yeah, sure. So I know it's a little different I'm sorry if I'll talk fast, but so for breast cancer, I know the questions are, is it access or is it genetic or is it both? For multiple myeloma, we really think it is genetic, and there are studies ongoing that are doing full next-gen sequencing for patients that have first-degree relatives, and so we know that we're starting to discover associations that are genetic, and so there is an increased incidence in African Americans. That doesn't seem to be due to exposure or anything else. It seems to be like they're born with a little bit of a tendency, increased risk, not a huge one. And so definitely we have a large African-American population here, lots of multiple myeloma in Memphis, and catching it early when it's like MGUS, or catching it right whenever it develops disease, is important to prevent problems. So they did a study in Iceland where everybody in the whole country, it's socialized medicine, everybody got, after age 18 that was willing to sign up, got their blood checked, and they checked them to see if they had MGUS, the precursor to myeloma, and then they followed them. And so they could watch with time as people would develop multiple myeloma from this precursor state. And so that's what they're trying to figure out. It was an amazing study. Basically 1% per year, these patients would get a mutation, and if you had MGUS, you had a 1% per year risk, which we kind of knew, but it further elucidated it. So they're going to try to figure out, can we maybe bend the curve, and when they're in that pre-cancer state, can we get them back? And it'll be definitely a very interesting area of research moving forward. So thank you. Thank you, guys.
Thank